Lucy McBride here, coming to you live, unfiltered, unedited from Washington, D.C., primary care doctor here. Today, I'm bringing you the incredible Greg Katz. Greg is a cardiologist. He's a educator. He's at NYU in New York City. He teaches residents. And like me, he's a communicator of nuance. The thing I love most about Greg, and we've only gotten to know each other recently, is that he understands that we treat patients, not numbers. That an LDL cholesterol level matters, but so does the person behind it. And so when these new guidelines came out in 2020 for 2026 in March for cholesterol management, unsurprisingly, I got tons and tons of calls from patients. Should I increase my Lipitor? Should I lose 20 pounds? What should I do? And I turned to Greg and said, what do you think? And we decided to talk. So here we are talking about cholesterol guidelines, humanism in medicine, and how to make sense of your numbers and apply this new information and guidelines to your actual life. So Greg, thanks for joining me today.
I'm so excited to be here. I'm so excited to chat with your audience.
Let's get started. What happened on March 13th with this cholesterol guidance? You wrote about it, and I loved your take on it. Tell me what that was. What was that the result of, and why did it come out? Why did we need new cholesterol guidelines?
Yeah. So, medical research is always changing. And the big professional societies, of which the American College of Cardiology and the American Heart Association are sort of the two big ones in cardiovascular disease, they got together and they realized, look, there have been a lot of new studies about cholesterol management and about the prevention of heart disease overall. And so guidelines come out when a group of experts, a bunch of different doctors from different practice settings, different clinical expertise, they all get together and they have these series of meetings over a period of months. They go through all of the relevant papers and then they make recommendations for how the rest of us doctors should potentially be managing these medical issues across all of our patients. And they grade all of these recommendations with a level of evidence and with a strength of recommendation. And so you'll see different classes and level of evidences in the recommendations. And those are meant to convey how confident we are about these things, that A, you should do it, or B, how strong the data is. But this is not a new study that came out, and it made a ton of news because it's a bunch of experts who've spent a lot of time going through huge numbers of papers. But I think the context of all of this is really important. This was not a new study. No patient was randomized. This is a group of people coming together and then negotiating their perspective about what does all of this evidence mean for how we take care of patients.
I think that's a really good, important point. This is not a new study. This is not new information. It is the sort of distillation of tons and tons of studies interpreted by experts and then guidelines being given. So, Greg, as you wrote about on your Substack, which I will link to in the show notes here, you made the excellent point that there are limitations of expert guidelines. This is one of my favorite subjects. Not to be anti-doctor or anti-guideline, we need guidelines. But tell me on a practical level, what's the limitation of a guideline? For example, the new guideline saying that most people should have an LDL, low density lipoprotein level of under 100. Tell me about what that, I can tell you my experience, but tell me what's the limitation of these guidelines in real life?
In real life, it's that nobody wants to take statins in my practice. But I think that whenever you're thinking about a guideline, you need to understand guidelines are decided about based on huge papers. And those papers study a whole group of different individuals. And there are some individuals who respond very well to treatment. There are some individuals who respond less well to treatment. People have side effects. People have preferences that they don't want to be on pills. But ultimately, this idea that everybody should have this, I don't think that that's the right way to practice medicine because, every patient is a different human being. And your set of individual risk factors is going to be different than the next person down the hall with their individual risk factors. And you can have a patient who looks identical on paper, the same blood pressure, same LDL cholesterol, same hemoglobin A1C, but one person has a family history where everyone dies or gets bypass surgery by the time they're 50, and the other one has a family history where everyone lives until they're 95 and then dies of old age. Those are different people, even though they look the exact same on paper. And you can extend that analogy to different people have different preferences. Some people are better living through chemistry people. If they think a medication will lower their risk, they're ready to take that medication. Other people are just not medication people. And my job as a doctor, and I think you look at your job in the same way, which our job is not to tell people this is what you should do. It's to say, my interpretation of the evidence is this. I think you will reduce your risk by approximately this amount. If you go on this medication, we achieve these results with it. But I'm just like not a believer in you should do this. And I kind of disagree with the guideline recommendations about like everybody should do this.
So Roger Blumenthal, the sort of head of preventative cardiology, was on the expert panel, and he is a good friend of mine. He was a mentor of mine at Hopkins, and I love kind of tussling with Roger because, of course, he believes in the guidelines, and of course, he has his finger on the pulse of every single piece of evidence. But just as you said, Greg, you can have two people with the same LDL cholesterol. The LDL, the low density lipoprotein, is thought to be the sort of the bad cholesterol, if you will. And they got there. Not only do they have potentially different outcomes, even with the same LDL cholesterol,
Yeah.
one may have a heart attack at 50, one may live to their 100 and not have any cardiovascular problems. The other important element there is that the mechanism by which they got to their high cholesterol may be completely different. You can have two different people with the same high LDL. One person got there because they are burnt out at work, they're caregiving for their children, and they are binge eating at night and depressed, and they have high cholesterol. The other person has high cholesterol despite eating a, Pinterest perfect meal plan and exercising, and they have high cholesterol because they are genetically predisposed. Medicine, the field of medicine would like to prescribe Lipitor to both. No,
Yeah. Well, I mean, they look the same on paper. They have the
that's right.
same
But
prevent
this, but
outcomes.
this gal,
Yeah.
to give this person Lipitor and say, see you next month or see you next, couple months to check your LDL is actually depriving that person of agency. For me, as a primary care doctor, to say you should be on Lipitor for that high cholesterol is actually like completely inappropriate. She may not even want it. But what I would say to that person is, hey, let's talk about how to work on habits that are realistic in your life, given that you're burned out at work, given that you have children and you're a single mom, to enable you to improve these cholesterol levels without medication, given that you don't smoke, you don't have high blood pressure, you don't have high, diabetes. And then the other person, I would say, look, if you have coronary artery disease, despite exercise and eating healthy, and you have plaque in your arteries, there's no kind of optimizing your way out of a genetic predisposition to heart disease. So again, we treat the patient, we treat the human, not the number. There is no algorithm for treating actual human beings. And this is where, as you and I both well know, this is what you love about medicine, what I love about medicine, is the patient story, not because I like talking to humans, I do, but because it's relevant. It is absolutely relevant. The way someone developed high cholesterol is relevant to how we treat them,
Yeah.
because my job isn't to say, here, take a pill for every body part, take a Lipitor for high cholesterol. If you have whatever medical problem you have, it's to say, let me tell you the options of how to get this under control. Some of it's lifestyle, some of it's medication, and we want to empower people with that information so they can then take it into their regular lives and exercise their
I
autonomy.
Yeah, I describe that dichotomy to patients as there's some things that are in our control and there's some things that are not in our control. And, we can adjust your medications, we can give you lifestyle tips, but we can't change who your parents are. And so on some level, there are uncontrollable things and we should try, it's the serenity prayer for health of,
Okay,
have
Greg, we speak the same language. Like, that's my book, is like the superpower in health and in life, right, is to understand where you have agency and where you have to let go.
yeah. And so, yeah, I think that just understanding who is this human, it really matters. And you had mentioned that if this person has coronary arteries, that gets like the next conflict in the guidelines of like, how do you approach the idea of a coronary artery calcium score, right? That's like one of the big things of the
So
guidelines talk about.
so let's talk about that. I want to go through nuts and bolts because we could talk about the relevance of people's stories and their, everyday lives to their cholesterol levels that show up in our offices. Let's talk about coronary artery calcium scores. Then let's talk about LPA, lipoprotein little a, which is, a hot button topic.
Yeah.
I've got a couple messages in my queue this morning about LPA. And then I want to talk about like practical, realistic ways to optimize, improve your cardiovascular health. So let's talk about coronary artery calcium scores. These are big ticket items. Everybody kind of wants one these days in my world. What about you?
I have some people who come in requesting it. I have some people who come in having never heard of it. I have some people who think that they should get it, but it's actually not the right test for them. And so I see the full spectrum of how humans respond to
And
that.
so, Dr. Katz, what's as a cardiologist, tell me this: what is the best utility? Like, we live in a world where people can basically order tests like off of a menu at In-N-Out Burger, right? So, like,
Yeah.
what is the sort of ideal person for this test? Like, what is the use case that you argue for it?
Yeah. So I look at I look at a coronary calcium score as basically it's a tiebreaker of how aggressive should we be in terms of prevention? Should we treat that borderline elevated blood pressure with medications? Should we treat that borderline LDL cholesterol when other things are taken into context with medications? How much do I need to push you on smoking cessation? How much should we be really trying to sort of hone in on those lifestyle factors that could be adjusted? But what a calcium score is, there's a couple of places where calcium score actually doesn't really have a role. And I think it's worth talking about those.
Let's talk about it.
So one is young people. And so I consider a man under the age of 40 or 45 or a woman under the age of around 50 to basically have a calcium score almost be a useless test. And
Mhm.
the reason for that is that calcium score is very likely going to be zero. And it's not going to tell me anything to update my suspicion about someone's cardiovascular risk. Because young people tend to have, if they have plaque in their arteries, that plaque tends to be soft plaque. And if you just do a calcium score, the only thing you see on a calcium score is calcified plaque. And that is a very late stage of the process of heart disease. And so a calcium score for a young person, and men have a lower age cutoff for that than women because men tend to develop heart disease at a younger age than women do, on average, not any one individual. But calcium score is it's a waste of a test because it's not informative. And so
You're
for
saying you're saying, let me say it back to you, Greg,
yeah,
that you're saying that for young people, young meaning men under the age of 40 and women under the age of 50, you find that it's pretty useless. Obviously, I'm sure there are exceptions,
if
but
there's coronary calcium in those patients, that's a, oh my God, really, really alarming piece of data. If there's no calcium in a woman under 50 or a man under 40, just like it doesn't change anything about how I'm thinking about
okay. Um, let's back up for one quick second. Am I still frozen, people? Someone said that I'm frozen. Um, anyway, so you can hear me, right?
it. I can hear you. Yeah.
Okay. Let's back up. What is a coronary calcium score? People don't even know what it is. I mean, not everybody knows what it is. It's a 3D look at the coronary arteries that are the
Yeah.
blood vessels that supply blood to the heart itself. That, if blocked, cause heart attack. Is that fair?
It's a low radiation CAT scan that looks to see if you have calcium buildup in those arteries. Everyone's heard the term hardening of the arteries before. Calcium score is looking for hardening of the arteries, but it doesn't tell you everything about cardiovascular risk. It just tells you one piece of the puzzle.
That's right. As I say to patients, it tells you about the plumbing. It doesn't tell you about the electrical system. It doesn't tell you about the structure of the heart. It tells you about the plumbing, whether or not you have calcified plaque in your coronary arteries. And as Dr. Katz, our cardiologist, just said, it doesn't tell us about soft plaque. So there's soft plaque that cannot be visualized on a calcium score, and there's hard plaque that is calcified that can be visualized. So just because you have a 0% coronary calcium score doesn't mean you don't have soft plaque. Can you talk about that for a minute and
Yeah.
what
So the process of heart disease starts when cholesterol gets into the walls of blood vessels. It's not supposed to be there. And so that causes inflammation. And then over time, the body responds to that invading event by laying down calcium, which I think of as almost like scar tissue. And so by the time you get calcium, it's this late stage of the process of heart disease. And very, very importantly, calcium score does not tell you anything about whether the plumbing is clogged. It just tells you whether the plumbing is rusted. And so you can have a really, really high calcium score and your arteries on an angiogram do not have a single blockage. You can also have a calcium score of zero and have a very high risk 90% blockage in a very, very important artery. And so the calcium score is a tool for risk assessment. It's not a tool to evaluate why somebody's having chest pain. It's not a tool to evaluate does somebody need a stent. It's just a data point that you're getting to help you to help influence your decision making about preventive strategies.
so helpful. I think the mistake that we make with regards to messaging the coronary artery calcium scores, Greg, is that people breathe a sigh of relief with a 0% coronary artery calcium score
Yep.
when that is only one data point, and you can have cholesterol plaque in there despite having a 0% calcium score. I mean, it's nice to have a zero score. It's nicer to have a zero score than it is to
Or you
have a
can have,
50. Like,
yeah.
we like zero. And I also think on the flip side, when you have a coronary artery calcium score, like my patient who I saw last week, who has a score of 75, she has no symptoms. She exercises every day. She doesn't have high blood pressure, diabetes. She's not a smoker. She doesn't have a family history of early heart disease. Like, there's no way that that plaque is obstructive because she has no symptoms
Mhm.
of it. And like that may just be an incidental finding that we are, of course, treating her for with cholesterol meds. But I don't want her to over index on that as like she's got this sort of widowmaker, right? Like a problem when she actually doesn't.
And too often, like doctors are guilty of over indexing on what that calcium score means. And
Yes.
it's I've seen too many patients who get a calcium score done who have no symptoms. They're just living their life having zero symptoms. And then somebody sees the score is high. And so then they get sent for a stress test. And then, like 10 to 15% of stress tests have either false positive or false negative results. And so then they get a stress test that may or may not be truly abnormal, but then that sets up an invasive procedure. And then maybe they get a stent that they might not have needed. And it's really, really important, not just that patients understand what the calcium score can and cannot do, but that your doctor is not going to overreact to the results and send you for a cascade of invasive radiation inducing exams and tests that you may or may not need.
Yeah, you said it. I think that patients also need to understand and doctors need to understand that cholesterol plaque in the arteries is informed not just by cholesterol levels in the blood. This
Correct.
message somehow hasn't gotten through, and I understand it if you're a layperson. Cholesterol plaque in the arteries is not just about cholesterol. You can have normal cholesterol levels your whole life and have cholesterol accumulation in the walls of the artery.
Yeah.
It's about inflammation, it's about shear stress on the walls of the artery, it's about blood sugar, it's about uh,
Yeah, it's
prediabetes
variable
and
blood up.
diabetes. It's
There's a million factors. We describe
yeah,
it as cholesterol is necessary but not sufficient to cause cardiovascular disease, and so it's a piece of the puzzle, but it by itself is not the entirety of the puzzle.
that's exactly right. What do you tell somebody who has a 0% coronary artery calcium score, who has other risk factors for heart disease other than high cholesterol, like they're diabetic or they have hypertension, and they're curious about that soft plaque, the
Yeah.
soft plaque that cannot be visualized on a coronary artery calcium score. What do you tell them about the potential for imaging that? Um,
So
and yeah,
you can do a test called a coronary CTA, which is a CAT scan with contrast that uses thinner cuts than a calcium score that can visualize those soft plaques. And if you have somebody who is having a chest pain syndrome or shortness of breath or tightness in their chest, or you think that they have a symptom of cardiovascular disease, a coronary CTA is a pretty reasonable test to get. The question of whether that should be used as part of a preventive strategy to visualize soft plaque, it's something that quite a few doctors do. I do in select patients, but that's a test that's not paid for by insurance. And in order to get that test covered, which the calcium score is also never covered, but the calcium score is $100 to $150. The coronary CTA can be various amounts of money. And so somebody wants that test out of pocket. It's certainly something that they can get, but that should not be a routine strategy for a lot of patients. And the data to sort of support that as a strategy to decide on preventive therapies is nowhere near as robust as we would like it to be.
that's helpful. So I think as we round out the conversation of the coronary artery calcium score, I'd like to say that it's a way of looking at calcified plaque, hard plaque in the coronary arteries. A negative test does not mean you don't have soft plaque, and a positive test doesn't mean you're destined to have a heart attack. It's just a piece of data.
That's perfect.
Secondly, there are other risk factors for developing cholesterol plaque in the arteries that are not cholesterol. Things that are risk factors for the development of cholesterol plaque: diabetes, cigarette smoking, hypertension, family history, and other sort of je ne sais quoi factors.
Yeah.
And we'll talk about the LPA in a second. To me, the biggest utility, Greg, in primary care of the coronary artery CAT scan is the intermediate risk person, as you said, the person who is in their 50s or 60s. They have a couple risk factors for heart disease. They have high cholesterol, and they're loath to be on medication for anything.
Oh,
Uh oh.
like,
Uh oh.
sorry about that.
Nightclub. It became a nightclub. So, So it's a tiebreaker, as you just said. It's a tiebreaker to help people. Okay, if you have a 0% coronary artery calcium score, that I breathe a sigh of relief. The patient does, maybe too much, but it allows us to say, let's really focus on diet and exercise to work on your cholesterol. But if it's a non-zero score, if you have a score that's 50 or 100, then I'm going to really push you on your blood pressure. I'm going to really push you on your, diabetes. I'm going to really push you on a statin in addition to lifestyle factors. It's not that, that's a failure of your lifestyle. Being on a statin does not mean you failed, you didn't exercise enough, you didn't eat enough broccoli. It's just it just is. So talk to me about the non-zero cholesterol score. Does that automatically mean you should be on a statin?
Of course, like nothing automatically means anything. And so I always tell patients it's not a moral failing to end up on a medication. And medicines are tools, and tools are only as good as you use them. And so I look at an elevated coronary calcium score. Importantly, I think you need to put into the context how that number looks relative to somebody's age and sex. And
Mm,
so most of the places that will do coronary artery calcium scores will give you a percentile of where this person stacks up according to their age, their sex, and sometimes their ethnicity. And then so there's this big study called the MESA study, which it stands for multi-ethnic study of atherosclerosis. And they looked at a very diverse cohort of people of both men and women across different races and ethnicities. And that's often used as sort of a guide for where somebody's percentile of calcium is. And so if you have somebody who is 80 years old and they don't have calcium in their arteries, that's pretty surprising. But a calcium score of 100 in an 80-year-old is very, very different than a calcium score of 100 in a 48-year-old. And if you don't put into context how much plaque does this suggest somebody has relative to how much you would expect, you can end up sort of miscategorizing people. And that's one of my issues with the guidelines is that it has these hard cutoffs for calcium score and what it means and which path that means that you should go down. But you need to interpret it in the context of who is this patient and also what are their risk factors? Somebody who has a calcium score of 100, who's 50 years old, but they have an LDL of 85. That's not necessarily the lever that you should be pulling. And so you need to think about who is this person? What are their risk factors? And what is their blood pressure? And high blood pressure it's such an underappreciated.
I agree.
It's called the silent killer. It should be called the boring killer because nobody likes to talk about it. It's not that interesting. But if you think about longevity and how likely are you to develop cardiovascular disease, heart failure, kidney failure, dementia, your blood pressure matters more than almost anything else. And so I spent so much time counseling patients on how to take their blood pressure at home. And so if you have an elevated calcium score and your blood pressure is not perfect, that is probably much more important than starting a statin unless your LDL is through the roof. And then you look at markers of insulin resistance and metabolic syndrome. And so what are somebody's triglycerides? They have low HDL. What's their waist height circumference? Do they have evidence of high fasting blood sugar? Is their hemoglobin A1C in the prediabetes range? You're integrating all of this information. And so most heart disease prevention is blood pressure, cholesterol, and blood sugar and metabolic health. And, there's a lot of other stuff, but if you get those three big things right, you would prevent a lot of heart attacks and strokes.
It's a great conversation, Greg. And the nuance is so key. And it strikes me as we're talking, as it strikes me probably every day, how s- tragic it is that people don't have access to physicians like you, cardiologists like you, who can understand nuance and who communicate context to the patient. As you said, not everybody with high cholesterol, according to the new guidelines or even the old guidelines, needs to be on a statin. Not everybody with a non-zero coronary artery calcium score needs to be on a statin. Now, because it may not be the mechanism by which they developed the plaque in the first place. They may not have even had high cholesterol to begin with. And health is not just about me prescribing a medicine or writing a prescription. It's about empowering the patient to act on the levers that they have control over.
Yeah.
But that takes time, and no one has time. So who should be on a statin? And let's talk about should people be on statins when they have normal cholesterol? Should people be on statins when they have high cholesterol and a 0%
Yeah.
heart scan? Should everybody be on a statin? I mean, there's that dumb saying, I really don't like it, that every cardiologist is taking statins and it should be in the drinking water. What do you make of that?
My thought is that, if you look at a person who has a low LDL versus that same person with a higher LDL, The lower LDL has a lower cardiovascular risk. How much that is lowering your risk depends on what your baseline risk is. And so, on average, over a period of about 5 years, statins lower your risk of a heart attack or a stroke by about 20 or 25%. And so, if you have a 1% risk over the next 5 years of having a heart attack or a stroke, and statins lower that to 0.75%, I think most people would not want to take a statin. But
So
if you,
that needs to be screamed from the hilltops, because I think we do not communicate risk to patients very well. That is so important. I'm just going to say that again, Greg, that statins in general can reduce your cardiovascular risk by 20%. But if your baseline risk is like near zero, 20% reduction of near zero is near zero. So you have to know what your baseline risk is to begin with. It's not like statins are going to guarantee you a non-heart attack, no matter who you are.
yeah. And so you look at somebody's baseline risk, and there's a bunch of different ways of estimating that risk. And you can get into the weeds of all of the different risk calculators and ways of figuring it out. But I look at it, I try to look at it pretty holistically. I ask about somebody's family history. What happened to their parents? Heart attacks, strokes, bypass surgery, stents, high blood pressure, medications, all of those different factors. How old were they when they started those medications? What are their siblings like? Did anybody in their family, grandparents, die young? And so you integrate that family history. And then you ask about what are the other risk factors? Like, how is this person's blood pressure? Do they have metabolic syndrome or diabetes? And then, do they smoke? Are they physically active? If they are physically active, how active are they? And I can't tell you how many patients who are not sure about how active they are. So I ask them, is your phone with you all the time? And they say yes. And I say, like, let's pull out your step counter in the room and figure out how much are you walking. And I've had patients who are shocked in both directions. Oh, I didn't realize I was actually walking 11,000 steps a day. Or other people who are like, oh my God, I'm only walking 2,000 steps a day. And, physical activity really matters for cardiovascular disease prevention. I ask about people's diets, and, you can get into the weeds on diet, but my very, very strongly held impression is that most people kind of know what junk food is. And a lot of questions about healthy diet are looking for loopholes in what they know to be true. And, like, you can get into the weeds, and that's a little bit of a glib answer, but I think it's directionally accurate. And so I ask people all of those things. And then I look at, what does their blood work look like? If they've had a CAT scan of their chest or a calcium score, how much plaque is in their arteries? How old are they? And then the other thing I ask people is, how medicalized do you want to be? How much do you want to try to individually triangulate your own personal risk? How do you feel about taking medications? How do you feel about about not taking pills? And that the statin side effect question is the thing that comes up all the time in
Let's
my practice.
please talk about it.
And so I think the statin side effect question is so boring because it's very straightforward. 8 to 10% of people who go on a statin will get muscle aches. If you're going to get muscle aches related to a statin, it usually starts somewhere between 1 and 3 weeks after starting the medication. And then it stops 1 to 3 weeks after stopping the medication. And so it's this very easily detectable and reversible thing. And there's a lot of cardiologists who think that statin side effects are nonsense. I take people at their word. And if you don't feel well on a medication, only an insane person would force you to stay on that medication when there's other options. And so
Okay.
I just very strongly believe people should not go on a statin if they are having side effects from being on a statin. The statins also raise your hemoglobin A1C by around zero point 0.1 or 0.2%. And so a small rise in blood sugar. And this will be fearmongered by a lot of the anti-statin folks on the internet as statins cause diabetes. And that's nonsense. One of my mentors in fellowship said that if a statin gives you diabetes, you are a Snickers bar away from getting diabetes anyway, which it's glib, it's ridiculous. But the point is that statins have a very predictable small rise in what your blood sugar should be. And if you're monitoring it, you can mitigate those effects. And if you're on the borderline or you're insulin resistant and you don't want to be on a statin, luckily we have all of these non-statin medications that we have the opportunity to use to lower your cardiovascular risk. And so statins are a tool, and tools are only as good as the way that you use them.
I love that. What about, you know what? Should we talk about LPA next? Because
Yeah,
I want to talk about lipoprotein(a). I also want to talk about these non-statin medications,
yeah.
like the Repatha medications, the injectables, um, and Nexlivit, and all these sort of, and
Yeah,
aspirin. So
what do you want to talk about? Yeah,
let's talk about LPA. So lipoprotein(a) is a headline maker right now, and I think it's great that we are now recommending one-time checks of people's LPA, because LPA, in my understanding, you tell me, cardiologist Dr. Katz, is associated with an increased risk for cardiovascular disease, and that it's not modifiable with lifestyle. So tell
Yeah.
me the skinny on LPA.
It's this genetically driven cholesterol particle where it's an LDL that's bound to a protein called apolipoprotein, lowercase a, which is where the little a comes from. And it does a couple of things. One is accelerates the formation of plaque in the arteries. Two is it is pro-oxidative and pro-inflammatory. And three is that it's pro-coagulant, meaning it makes your blood stickier and more likely to clot. And probably that is the reason why evolution has not sort of gotten it out of us, because back on the savannah, having a propensity to have your blood clot would protect you against hemorrhage. And so LP little a probably actually had a teleologic benefit, which is why it still persists. But how I think about that value is it matters how high it is, and it also matters what is the context of your family history. And so the combination of a very high lipoprotein little a plus a strong family history of early heart disease, meaning heart attack, stroke, stents, or bypass surgery before age 60, that's a real red flag. And that's somebody who I use the LP little a. It's a tiebreaker for, should we treat borderline blood pressure? Do I need to really push you to start an exercise regimen? How should we be thinking about smoking cessation? Should you go on metformin for prediabetes? Like, the LP little a is the tiebreaker for all of those long-term clinical decisions that we're going to be making over years and years and years. The drugs to treat it are in clinical trials. And so at some point over the next few years, we'll probably have data that lets us know whether that actually lowers risk of heart disease to treat it directly. It's very, very promising, but until you have the data, you're left with a lot of skepticism.
Yeah. I think the mistake we make often in medicine, you tell me, is that if LPA is high, is assuming that if LPA is high and increase your risk for cardiovascular disease, then lowering it is going to be better. Now, that may be true. That makes sense intuitively, but we will need to have studies showing that lowering it actually reduces the risk. And also the mechanism by which you lower LPA is going to matter as well.
Yeah.
In other words, just lowering the test doesn't necessarily improve outcomes, but those studies are being done, and there's no direct um, target medication that targets LPA at this moment. In fact, I had a patient who came in February. She has a very high LPA. I have her on Crestor, and we have a strict LDL goal of 70 or below because she has a positive coronary artery calcium score. Her LDL was like 100. I upped the Crestor, the rosuvastatin, came down to 70, and she insisted on having her LPA rechecked, which I didn't want to do because
Probably went up a little bit. Yeah.
it went up. And she was like, "Oh my God, it went up." And I'm like, "Well, this is why we don't want to recheck it. Not because I don't like looking at, you know, these numbers, but because it doesn't actually change anything. The target is still that LDL. So if you have a high LPA, it increases your risk, we think, for atherosclerosis. And what it means is then we need to be more aggressive about your LDL, the known target for these guidelines."
Yeah, that's exactly how I use it. And then for a subset of people who are very, very elevated family history risk, who also have a markedly elevated LP little a, I will occasionally use aspirin as a primary prevention strategy based on, thinking about what are the levers that we have to pull and how that is a pro-thrombotic, meaning pro-coagulant type of particle. But that's a very, very small subset of people. It's certainly not all comers.
Do you predict, Greg, that we will someday, or maybe in the near future, have a medication that targets LPA specifically?
Yes.
You
Those
do?
are those medications are in late stage trials, and there's a bunch of different ones that are being tested. And the preliminary data on lowering the numbers and not having side effects seems really good. But like, the history of medicine is littered with things that quote unquote should have worked that didn't work when they were rigorously tested. And so I will wait until we have data that lowering LP little a lowers risk of heart attack and stroke and doesn't cause other medical problems before I'm ready to prescribe it.
So again, statins don't lower LPA.
No, in fact, they raise it a little bit.
They raise it. And
But they lower
statins will lower your LDL cholesterol, which is very well established as the clinical therapeutic target. So if you have a high LPA and we don't yet have these drugs on the market to lower it, as Dr. Katz just said, I keep calling you Dr. Katz or Greg. I'm just flip-flopping,
No,
depending on my mood. And if you have a high LPA, the target is the LDL. It's also the other things we've been talking about. It's not just the cholesterol. It's your blood pressure. It's your diabetes. It's your prediabetes. It's your cigarette smoking. I'm using a lot of GLP-1 medications. So
Yeah.
GLP-1 medications are wonderful. Unsurprisingly, the GLP-1s, the Ozempic, Mounjaro, Zepbound, Wegovy, help people with atherosclerotic heart disease and preventing, cholesterol plaque because they the mechanism of action is so sophisticated. They actually help process cholesterol. They help reduce inflammation. They help with diabetes. They help with blood pressure. So it wasn't surprising to me. I'm guessing it wasn't surprising to you that the studies came out and showed, surprise, they reduce cardiovascular risk.
No, not
It
surprising at all. But also, sometimes people will have a transient rise in their LDL while they're in a weight loss phase. And so I always wait. Sometimes it'll drop, sometimes it'll go up. I always wait till somebody has sort of steadied out in terms of weight loss before I conclude about where their LDL is actually landing. And so you can overtreat, you can undertreat. And it's just important to think about like where it's another just data point about what is this person's journey as a human being and not just where is their LDL.
right. And if we're going to riff on that, if I'm going to riff on that for 1 second, the mechanism by which someone developed, metabolic syndrome or metabolic insufficiency is also variable. For some people, it's because of, binge eating. And for other people, it's because of a family history. So it's interesting to watch people on GLP-1s sort of untangle, behaviorally, psychologically, and metabolically how they got to where they were and how that's being sort of untangled, which can then inform how you treat the specific elements of their metabolic problems. If that makes sense. I mean, I don't know. As I've written about numerous times in my newsletter, I think Ozempic and the GLP-1s are very sophisticated mind-body drugs. They give us a lot of insight about people's behavior, their relationship with food, their relationship with exercise, their relationship with their own body. And so to the extent that they reveal sort of what's under the hood in people's lives and their metabolic health, what's genetic, what's environmental, and how to know the difference, it's extremely empowering for patients who are getting metabolically more efficient. There are downsides to GLP-1s, major downsides. Like I have patients whose eating disorders have been, reawakened. I have patients who have pancreatitis because of GLP-1s. I have people who are smaller have a lower body weight, but are frail and weak and have lower muscle mass. So it's not a panacea, but it is an interesting modality in conjunction with all the other things we're talking about, lifestyle and meds.
They're tools, and tools are only as good as how you use them. And so, GLP-1 is a wonderful medication when correctly used, and just like a statin is a wonderful medication when correctly used.
Right. So can we talk about exercise for a minute, Dr.
Yes,
Katz?
I love that. I used to be a personal trainer before I went to med school, so I
Oh
love
my
it.
gosh, you're like the jack of all trades. So, um, I think most people are aware that exercise is good for you, whether it's to help prevent diabetes or dementia, it's good for mental health. And most people in my practice who aren't exercising as much as they should
Uh-huh.
don't not exercise because they aren't aware of the benefits. It's more of a, some barrier in their lifestyle or they don't have time or they just haven't found something they like. So what is your advice to the patient who's like, I know I should exercise?
Yeah.
What does the cardiologist say to the person who's trying to get motivated and organized to exercise?
So I ask patients all the time, how active are you? And the most common answer I hear is not as active as I should be. And so it echoes your point of people know. And my advice is very straightforward. The best type of exercise is the one that you will do most consistently, which is the one that you like the most or the one that you hate the least. And I don't care if that is yoga or it's on the treadmill or the elliptical or it's lifting weights or it's going for a brisk walk. Movement is important. And I tell my patients all the time that people who move generally tend to feel pretty good. And people who don't move generally tend to feel old. And so figuring out what works with your lifestyle and what you despise the least in terms of movement, it's just a really vital thing to learn about yourself. And I never will castigate somebody for not being as active as they feel like they quote unquote should be. But I will encourage them to think about where are the places where they can get a little bit more movement in. And I am agnostic as to what type of movement that is.
I love it. I think, as you know, we live in this world of like prescriptive advice and protocolized exercise routines. And like,
Yeah.
it's just discouraging for the average mortal, right? To be told that you have to have 150 minutes a week and it has to be 3 days a week of strength training. And you got to wear the weighted vest now that you're a middle-aged woman. And I'm with you. Like, let's make things easy for people, not by saying you don't need to exercise, but by helping them find things they like and things that are sustainable and realistic in their actual lives, not in some aspirational life where you have oodles of time and a personal trainer like Dr. Katz kind of whipping you into shape. Um, I do think that strength work in middle age is particularly important. As we age, we need to keep muscle mass going. And I think um, that is undervalued in general, but I don't think I think that memo has gotten through to the general public.
Yeah, strength training is intimidating for a lot of people. And so you take somebody who's never spent time in a gym and you say, go into this gym and strength train. What that does is it makes people feel like, why do I feel so like not confident about what this place is like? Everybody looks like they know what they're doing. It's intimidating. And not everybody has the money to join a gym. Not everybody has the money to afford a personal trainer. I always tell people YouTube is a great source, and look up body weight exercise. I think the New York Times had like a 7-minute workout that you can do with no equipment. And so, uh, whatever you can do to reduce the barriers in your life to just being active is really, really important. And even if that does not make the numbers on your medical chart budge, it will lower your risk of all the different diseases that you're worried about. And it's tough to figure out exactly how to quantify that, but that doesn't make it less important.
I also tell patients, trick yourself into exercising. I do this too. I schedule like I have a tomorrow night I'm going out with my friend Jen out walking. It's social and I like walking, but like I probably wouldn't go after work by myself on like a rainy day. So like but I'm not going to disappoint her. So do the two first, socializing and walking at the same time. Um so let's and Jen, you better not cancel. Let's talk about eating. So in the same spirit of exercise, people know that broccoli is good for you and they know that candy bars are not good for you, but we're human and we tend to gravitate towards comfort foods, and food in the US is hyper palatable and not always, the healthiest. What's your sort of top line advice for people regarding diet when it comes to preventing heart disease?
Some people are really good at following a prescription with specific rules, and some people do better with just overall guidelines. And if there's this really fascinating study called the treat trial, which was an intermittent fasting study where they basically took two groups of people, and one group had a regular calorie restricted diet, the other one did intermittent fasting, and then they followed them, and they found that over a period of like 8 to 16 weeks, weight loss was the same in both groups. But if you look at individual participants, you see that there's a bunch of people in each group who gained weight and a bunch of people in each group who lost weight. And it really echoes to me, you need to individualize this stuff. And so understanding what is your dietary kryptonite and where do you slip up or where do you struggle to make the choice that you know in your brain that you should be making is important. And some people do really well up diet prescription. I eat this for breakfast, this for lunch, this for dinner. Some people do better with, I have a cheat day. Some people do better with a time restriction of, I don't eat anything before noon and then I'm allowed to eat in moderation after that. And there's a million different strategies of how you do it. And the best one is the one that actually fits with your life and with your preferences. And so I think it's impossible to give a blanket piece of advice, but if you have a conversation with somebody, it often will reveal itself.
Greg, you sound like a primary care doctor. I don't know how you have time in academia at NYU as a cardiologist to break down the nuances of people's sort of everyday behaviors and the way they eat, the way they move, their LPA. I mean, this is to me the most existential problem in healthcare right now, or maybe in addition to other existential problems in our country, that doctors don't have time, patients don't have time with their doctors to help sort of decode their lab tests, their LDL cholesterol, their LPA, their calcium score. They don't have time to have the wisdom that you have imparted to them to then take into their regular lives ways that are practical and realistic to reduce their cardiovascular risk. How do you have time? What do you think is the sort of the solution to the patient out there who doesn't get a call back from their cardiologist, who's been told take a statin or else, like, talk to me about the sort of state of healthcare right now and cardiology in particular.
That's really hard. I'm not smart enough to know what the answer is. I think ultimately, patients can be better, can sort of prepare themselves for visits by thinking ahead of time about where do they envision their health problems to be. And I'm sure you're going to talk about this in 10 million different ways, but thinking about a doctor's appointment as though it is a consultation where you're getting the questions that you want answered and not letting the doctor run their agenda is, I think, the best piece of advice I can give people. Because I know from a patient's chart and their medical history and the blood work and the imaging tests that I see, I know what I would talk about in a vacuum, but patients will often have the conversation go in a very, very different direction. And that direction is more helpful to them when you go into the visit prepared about what you want to ask about. And you should look at the doctor as a consultant for your overall health. And, you know, think about who the doctor is. If you're going to an ophthalmologist, they're probably not the person to talk about what are the best lifestyle things to manage your blood pressure. But I think that every doctor is a little bit different and every patient is a little bit different about what they want to get out of it. If I had a solution or like a 30-second answer to your question, I think I'd be in a much fancier office. But I just think it's really, really hard to know what to do on a societal level.
Yeah. So just to plug my book, there we go. Just to plug my book, Beyond the Prescription, it comes out with Simon & Schuster in August. And it is actually that. It's trying to help patients be more empowered as they navigate this broken medical system where they have a 5 or 15-minute appointment with a doctor who is well-intended but just doesn't have time to help them understand the nuances of their health. And then they're naturally then drawn to the wellness industry, which again is trying to help people. It's wellness is good, like I'm for it, but is equally prescriptive and aspirational. So my book that I've written is helping people kind of pre-package themselves, as you said, to bring to their doctor's office, whether it's a cardiologist or a primary care doctor, to help them do a little self-reflection before they show up at the doctor's office, because so much of health is about our own stories and our past and also our definition of health to begin with. Some people don't want to take medications no matter what. Some people would rather, you know, take this risk than do this intervention.
Yeah.
And so the first thing I tell people, and it's the same thing you just said in a different way, is understand what health looks like to you. Like what do you want out of this visit, and run the agenda yourself. That's patient-centered care right there. It's just listening and helping understand the person and then giving them the tools they need and they want. And, I think that if that could be scaled nationally, that would be great. Who knows?
I ask patients all the time, what would make this a successful doctor's appointment for you? And if you just shut up and listen to what the patient has to say, it often takes you down a different path than you would have gone down otherwise. And so I think that the more patients go into the appointment with an answer to that question, the more effective those appointments can be. And if you have 10 dedicated minutes to act with 15 dedicated minutes to actually focus on a specific patient's medical questions, the amount that you can get done in a discussion like that is real. It is much more than you would think based on how that length of time sounds like it would be.
It's such a good point because you and I both look at charts before people come in and you're like, okay, this is the lab test they had in advance and this is what I want to talk about. But just because I want to talk about something doesn't mean that's what they want to talk about.
Yeah.
So I think patient-centered care, time, rapport, trust, and importantly, as you and I both try to do, not moralizing human behavior. Like we're all trying to do the best we can, right? We all want to exercise and eat healthy and live forever, but that's not realistic to like be perfect. So I think the fact that you're not moralizing people's health and actually giving them agency is really, that's healthcare. That's what healthcare should be. Greg, anything else? Any last minute? Where can people find you on Substack? Like, tell me how to find you and how can they come see you as a cardiologist if they're in New York?
GregoryKatz.substack.com. My newsletter is very cleverly titled Greg Katz MD. And if I work at NYU, and so if you Google my name at NYU, I have appointments available. The portal is not great for making appointments. You need to call because when you talk to a human, you get in much faster than when you wait for an appointment that's available online.
I can't wait for one of my newsletter subscribers. There are 39,000 of you people coming back and telling me, "Hey, I saw Greg Katz as a cardiologist, and he's awesome." And he's like, that would be such a win. That'd be such a win. So whoever's out there looking for a cardiologist, see Greg. Not because you're probably looking for business, but because it's just satisfying to think that a patient would have learned something here and then taken it to the right person. Um, Greg, thank you so much for joining me. I learned a lot. I think our listeners learned a lot. And let's do this again.
I would love to. This was a blast. Thanks for having me.
Okay, take care, everybody. See you next time. Bye.